All right, excellent. Welcome everybody to the Mirror ICH Grand Rounds. This is a monthly meeting that we've been doing for about a year and a half now. It's sponsored by Integra, who makes the Surgiscope and also funds the Mirror Registry, which is a multi-center registry that we've been doing for a year and a half as well. Oh, sorry, even more than that. And we've enrolled over 100 patients in that real world minimally invasive ICH registry. So this is in partnership with Integra and with the registry. And the purpose of the Mirror Grand Rounds is to increase the conversation of how to perform and when to perform minimally invasive ICH evacuation, to have some dialogue between the major moments when a trial is published, and to make these small advances that develop the field and build a community around this and share expertise in patient management and how to perform the surgeries and all the kind of smaller steps that happen between the publication of major trials. And so today we're very excited to invite Abel Huang from Taiwan, who is professor of neurosurgery there at National Taiwan University Hospital. He's also an entrepreneur, and he came to the US in 2014 and did the Stanford BioDesign Fellowship for a year, and then formed a company to develop a minimally invasive ICH evacuation device that recently got FDA approval or clearance to be used in the United States. And so he's going to share his thoughts on minimally invasive ICH evacuation, his experience going through this device development process, and also his thinking around minimally invasive ICH. He's really the pioneer, I would say, in doing ultra early evacuation. And he published this paper in 2011 that showed that this is something that you can do safely. And that was following some other papers that had commented on how early evacuation, ultra early evacuation may not be safe. But the techniques that he showed that you really can do it safely. And that really ignited the field and inspired other people like me and others on this call to start doing it ultra early as well. So thank you so much, Abel, for being with us today. And looking forward to your talk.
Yeah, thank you so much, Chris. It is really my honor to give this talk. And basically, it's not like an academic talk. It's like the story of us tackling the ICH on device innovation. So I call it connecting the dots, because I never thought of creating a company and become a CEO. But I enjoy the process very much. So it is my honor to share with you my 10-year story on building a small medical device company. Yeah, so first I'd like to show to you that device innovation can help our patient. I think we are all winners of that. And then I will show you the BioDesign journey, and also thinking about future, how we can work together to help our patient in the era of AI and brain-computer interface. So thanks for Chris' introduction. Yes, I'm the clinical associate professor of National Taiwan University Hospital and also the CEO of International Medical Service Center of my hospital. So basically, I do minimal invasive brain surgery for brain tumor and cerebral vascular cases. So this is like a endonasal surgery for skull-based surgery. We tackle the meningioma through the nose. And I think the 3D endoscope help us to do the suture, dura suture. I think when you approach this EEA, you can easily remove the meningioma, but the hard part is repairing the dura near the ICA and the optic nerve. So during that process, we will use the 3D endoscope, and we have more confidence because the endoscope has less depth perception than the microscope. So I think it's a good complementary using microscope and the endoscope. So this is one example that device innovation help us to make minimal invasive surgery, or else you need to do a large bicoronal craniotomy. So now we can go through the nose easily, tackle this kind of tumor. So my lab focus on ICH, so some minimal invasive surgery and also some neuroprotection and neural repair work. working with basic scientists. But I will only show a small part of this, but I think this is a very important part for ICH in the future. So our strategy is a multidisciplinary team and international collaboration. These photos are taken about 10 years ago, like this is Chris here. We have great discussion on ICH, minimally invasive surgery. So my experience of fellowship, I have three fellowship. One at Harvard, where Peter Black is building the intraoperative MRI with their MIT colleague back in 2005. That's when I think that we can really participate and build a new device. And 2008, I did fellowship with Michael Lawton at UCSF. You know that he is a microscope expert, but he admit that there is some need for endoscope to, especially when you clip the aneurysm, you need to see the perforated underneath. You have some depth angle if you use the microscope. You can use the endoscope to check for the patency of the perforator. So he worked with Tice to come up with this endoscope that you can plug in and work with the microscope. And I think it's a really good thing that microscope expert can work with the endoscopic expert. So then when I did BioDesign Fellowship, I think we can really make a device. So why we thought of making a disposable endoscope and a portable system is that I think ICH sometimes is a very emergent surgery. So we want the regional hospital neurosurgeon that they can perform this kind of procedure instead of transferring to our third-tier hospital. Because I witnessed many delays. Many patients want to transfer to the best hospital to get this kind of surgery. But I think many patients deteriorate, and then when the patient arrive, maybe it's useless to do this kind of surgery. So I think in some cases, ultra early surgery is very important. So we are all winners of the medical device innovation that helped many patients in our field. Mount Sinai has been the leader in endovascular field innovation. And the brain tumor radiosurgery, the story of John Adler, I think you guys all know about that. And I participated a little bit in the intraoperative MRI innovation early on. And the scalp base, I think we all know that the endoscope, EEA, and I also like the transorbital approach, which I will show you my new idea of using transorbital approach to tackle deep-seated basal ganglion ICH in the later part of my talk. Yeah, so the fact is that all neurosurgeons always want to make their surgery perfect. And we think in our brain a lot about the rehearsal and simulation. That's how we invent a new procedure to improve our procedure or surgery. But inventing a device is a different story. You need to work with engineers and business people. So this is the Stanford BioDesign program. Yeah, Chris told me that you also have a program at Mount Sinai, which also have a very successful exit recently. So I think this is not only about neurosurgeon. We need to work with business people and also engineer to come up with some device that's viable in the market that can make meaningful innovation. So I think this is very important, and we need to learn about this. So the story about John Adler is also a very good example. So this is a case study. You know, back in 1988, he had this idea of doing the radiation using robotic arm from different angles, and this is his patent. But the first case that he did at Stanford was very terrible. So the patient is not doing well, and he mentioned that many of my closest colleagues at Stanford think this is Adler's folly, and he think he was like being immersed in a craniotomy. I think when you do a startup, you will have highs and low, highs and low. Your emotion is the same. So his company almost ran out of cash, and he had need to come to become the CEO again. And Taiwan has some investor to help this valley of death. And later on, this company become a very successful one, as you all know, Accurate. So almost half of those patients that needs brain craniotomy for brain tumor now just needs radio surgery. So I think this is an inspiring story. I'll share, and then I'll share with you my story. I think we are not successful yet. We are a beginner in medtech startup, but I think what we do is significant. So this is my story, why I want to become a neurosurgeon. My grandfather has a brainstem glioblastoma. At that time, it's an untreatable disease. Uh, right now, we can do surgery for this patient in selected case, but the outcome is still not good. So I I was very young, and I think I cannot accept that there's such thing as an untreatable disease. So I told my mom I want to become a neurosurgeon that can treat this kind of disease. So my grandfather died very quickly after the diagnosis. And then my passion and my dream, everything I do in my child life, I think I want to tackle this disease. But when I become a neurosurgeon, I realized there's much more room for improvement. This is like ICH, we can remove it, but the damaged neurons, we can do nothing about it. So people talk about stem cell and using neural repair strategies, and our lab work a lot on that, doing collaboration with basic scientists. So I really like this concept that when we meet a difficulty, it's actually opportunity for us to improve as a neurosurgical community. So every time I meet very difficult cases, I'm very excited to discuss with my colleague how we will approach it. And if it's a good approach, we want to let the community know and improve further. So similarly, I had this concept. So I went to the Stanford BioDesign program where we sent doctors to Stanford to work with engineer to solve some problem, unmet need. Yeah. So this is John Adler here, and so I talk a lot with him because he has new innovation, and also work with Taiwanese investor. And this is at UCSF, Dr. Pasad, which passed away. He's my teacher for ventricular scope, and we really miss him. Yeah, and there are many colleagues that we work together. So I think how we can tackle ICH, the device innovation is just a small part of it. The first thing we hope we never our families never have this disease. So prevention is very important, but I think that's for the drug company industry responsibility to control the blood pressure and risk. And timely diagnosis and treatment, I think Mount Sinai is at the cutting edge of this, working with Vis AI. Yeah, so I think this is a part that AI can contribute to. The other is neural repair strategy. I will talk a bit about it, and also neuromodulation and brain-computer interface. So we all know that ICH caused by rupture of the small perforators in the brain, and sometimes it's life-threatening disease. And in the world, each year, almost 4 million patients receive this kind of surgery, and the mortality rate is still as high as 30%. So this Asia and Africa has high risk of ICH. So in Taiwan, we are very in Taipei we are very crowded. We have a very crowded city. For example, the cyclists have ICH. He will be brought to the medical center within 10 minutes, and we can do the surgery if needed. In most cases, within 4 hours, and that's the paper we published. Chris mentioned back in 2011. So what we learned is what Chris taught us is early and effective is very important for ICH minimal invasive surgery. If in delay cases, you cannot treat it with minimal invasive surgery, you may need to remove you may need to do craniectomy. So at Stanford, we want to build a device that can go through the sockets to remove the clot and do good hemostasis. And back then, the most popular class is called How to Start a Startup by Y Combinator. So a little bit about Y Combinator. At that time, the president is Sam Altman. Yeah, now you all know about Sam Altman, but not that at that time, not too much people know about him. But the Silicon Valley people know him very well. The most famous exit is Dropbox and Airbnb. And back in 2015, they started biomedical investment. So I was lucky choosing by then. So I heard his talk, and I'm glad that Sam uh, invested in our idea. At that time, we have no device. So the interview is very interesting, which I will share. Their slogan is "Make something people want." Yeah, not something people need. That's a little bit different, like a philosophy. So at the website, you can see at that time they invested in AI and robotics. So that was like 10 years ago. So they look for the idea, product, the team, and the execution. So they will invest in the good innovation. So for the brain surgery, I think ICH, the traditional is a very large craniotomy and retraction of the brain. But sometimes if you over retract, there's a brain edema or rebleeding. I think this is the ICH is almost the first neurosurgery we do as resident. So sometimes you retract to see more, and you will do damage to the normal brain tissue. But for experienced neurosurgeon, you can do this easily, like minimal invasive. But I think we should create a device that goes through the sockets, and using a trocar, we can use endoscope to evacuate the hematoma and do good hemostasis. So we created a company to integrate the endoscope with suction irrigation system, because I think the balanced suction irrigation is very important, and also hemostasis in this kind of minimal invasive burr hole surgery. So just like Chris, this innovation of scuba technique, I think it's a balance of the suction irrigation. So this is a slide showing that the traditional craniotomy, you need to do a corticotomy about 3 centimeter on the normal brain tissue. And the minimum invasive surgery, you need a 2 centimeter corticotomy. If you integrate the endoscope with suction irrigation and cauterization, bipolar cauterization, you can do this successfully through a very small, less than 1 centimeter corticotomy. Yeah, so I think this is an example that device innovation can help us improve the surgery further to cause less harm. So at that time, I think the most important thing about minimal invasive surgery is the balance between minimal invasiveness and also the completeness of clot removal and secure hemostasis. Because sometimes near the corticospinal tract, you don't want to remove too much of the clot, just some adequate decompression. But if you remove too much, you might risk damaging the important tracks, adjacent tracks. So integration of medical devices is very important, like the working port, for the cauterization devices, and also a hemostatic agent. Let me see. Okay, yeah. So this is the device we created, and the integration of the endoscope suction irrigation system, the portable system display, also with some simple navigation functions so that you can use at regional hospital, or in the future we want to use this in like Africa, because not every Africa hospital has a navigation system and a endoscope system. So at YC, we need to teach, let these IT people know that what we are doing as neurosurgeons. So the interview is only 10 minutes. They will decide in 10 minutes whether or not they will invest in you. So we created almond tofu mold using the Halloween mold, and inject ketchup into the brain, and let them try to evacuate using industrial endoscope. And then they were pretty excited, like they can do brain surgery, and we successfully get their attention. And then and we are very lucky that our coach, Paul Booth, his daughter is actually had a brain surgery, so he know there's many problem in neurosurgery, and he think this is a big issue. So he decided to invest about 120K, and later on it's like 7% of your company. The first thing he told us is that it's not your money, it's investors' money. I think that's a very good concept for entrepreneur. You really need to use this money very carefully, and you need to be relentlessly resourceful. That's why we learn in YC. So every entrepreneur at YC is very frugal. So you focus on the product innovation and show it to the user, whether they like it or not. Will they pay for it? Will they recommend to their colleagues? If not, you go back and improve it, and go back to the user again. So similarly, we have a small community of neurosurgeon. I think this good cycle is very effective. So I think medical device innovation is very complicated. This is a graph about the BioDesign program, but many people ask us if YC did help us on innovation. I think they did, especially on the concept. The concept of early stage startup, you need to get things done very quickly. So they help us in many parts, like partnership and prototyping. In 3 months, we created a ICH model in pig in the Wake Forest inside the city, and evacuate using the prototype. And then we can do the Y Combinator demo day, a lot of rehearsal before that, just like, so I told my colleague that I do 75 time pitch, 2 minute pitch for 75 times a day. Um, I think I don't do that much rehearsal before brain surgery. So I think this is ridiculous, but that's the culture in Silicon Valley, and I enjoyed it very much. Yeah, so this is the demo day. So there's like 400 VCs worldwide. So I enjoy this presentation. It's only 2 minutes, and we have some Stanford BioDesign colleagues, as well as Singapore and China friends. So after that, they will give you a plus, and then you can know that they want to have coffee with you. So the ecosystem in Silicon Valley is very effective. After 5 or 10 minutes of talk, they will tell you that whether or not they will invest in you. If they will not, maybe they will introduce their neighbor who will be interested in your startup. So I enjoyed this very much, and I got addicted to espresso during that time. So after that, many startup lands like 10 or 100, 10 million. Our startup only got 3 millions from friends, family, and fools, but then we can move very quickly. So after YC, we still gather around almost each year, except the COVID pandemic. Yeah, I enjoy the YC community very much. So after you got the money, you need to integrate. For example, we need to integrate the camera, the software, the hardware, and do the manufacturing and the clinical trial. So we work with some company. I think this is very important for ICH, how we can tackle and to minimize damage to the important tracks and also the vessel, especially now we can know where the bleeder is. For example, if there's a spot sign case, we can think about an angle to secure the bleeder and minimize damage to the corticospinal tract. And we are very frugal. We use the cadaver head that the resident use. After they go to dinner, we will play around using our prototype. So this is basically free. So later on, they have some milestone. Now they are rolling out, and Chris and many of our US friends help very much in the design. We have almost 18 prototypes, and now finally we got approval, and Sutter is our representative in US. So right now I come back to clinical neurosurgery because I think there's still a lot of unmet need. So there's a team working, ClearMind team is still working very hard on this to make this into the market. So this is the first case we done in another hospital in Taiwan, Chang'an Memorial Hospital. This is the pre-op and post-op. The Dr. Lee used the display and remove the ICH effectively within 1 hour. So this is the patient walking in, and he can speak for left dominant side ICH. I think that's a very good recovery. And we have some press release because we have many industry partner in Taiwan. And also this is Chris helping us doing some first cases in US. This is during COVID. There's some case done in the United States. We cannot be in the OR to help him, but the CT look pretty. The first case that they done looks pretty good, and other Cleveland Clinic, Mark Payne, and then Northwest, we have some workshop. And we are very lucky that we work on this all together for almost 10 years, and the guideline, there's a paradigm shift. I think this is very important. So previously, we think it's important to show the minimum invasive surgery can save life. Right now, we have to show that it can have functional recovery, improve functional recovery. So I think we are at this stage. So we also have some discussion with Medtronic people, and we work with the industry leaders in Taiwan. For example, Logan is the manufacturer for your iPhone cameras, and they have more exciting technology for your next generation iPhone. So they are really the leader of the camera in the industry. And there are many public companies that we work with. And I'm very lucky I have a neighbor called Jane. They created almost 30% of the the cauterization devices in the whole world. They are the manufacturer partner for Ethicon, Medtronic, Integra. Oh, also the sponsor of this talk. Yeah, so I think this is what we call connecting the dots, like everyone working together. I enjoy this very much. So this is the first part of my talk. I think ClearMind is the company that we created, now run by my colleagues. I think we will be very successful if we work together. I think we can decrease the mortality and improve the functional outcome and save because the less hospital ICU stay, we can save some money for this patient and also the hospital. And the regulatory pathway was pretty quick. And working with new Medtronic, we can be scalable. So this is the first part. But I think startup is very hard. I think it's harder than neurosurgery sometimes. But you need a team, and you need to never give up. Like Chris and I, we are very passionate about cycling. This is Greg LeMond. He's a very good rider, and he said it never gets easier. You just go faster and finish the Tour de France. Yeah, so in the Silicon Valley, we also encourage each other. When we the founders, they also like to say this, to share this, and keep going fast. Yeah. So the next part, I want to show you that you all know the Dr. Predilla pretty well. So I think he is very brave to and also effective to come up with this NEJM paper that showed that its minimally invasive surgery is effective for lobar ICH. But so like my colleague will tell me, hey, why is this not working for deep ICH? So deep basal ganglion ICH is now the unmet need. I think that Chris and many leaders in this field now focus on this field. So I think what we learn from brain tumor surgery, we can also apply to ICH. And this is something not so intuitive. This is a part that we do a neural repair with working with the basic scientist. So we think about when we remove of the clot minimally invasively, then sometimes we put in a flow seal or surgery flow. If these biomaterials have neural repair properties, that will be very ideal. So we created some sequential release gel foam. The first is you can have anti-inflammatory and later on neuroregenerative. Edaravone is what you use for ALS, and it's used for the antioxidants. Yeah, so like anti-inflammation in the acute phase of ICH, it might be useful. So we use this kind of drug, and also minocycline has this property as well. So we use this in the ICH model, and this is the first time we saw the really neuroregeneration around the ICH cavity. So we are very excited and publish this and make to the cover of the advanced functional material. But the hard part comes, it's very hard for you to have one drug to deliver locally to the brain. Now we are talking about two drugs. So we have problem about continue working on this project. So it's a very hard project, but I think maybe in the future we can work together on things like this. So after we evacuate the clot, maybe we can put something locally. Since the damaged tissue is around the ICH perihematoma zone. For ischemic stroke, it's not like that. When you want to use regenerative strategy, the volume is much larger. The damage part is much larger. So I think we should use a local regenerative strategy in ICH. It makes more sense. So as a CEO of International Medical Service Center, we do a lot of surgery in Indonesia and Southeast Asia. So this is the endoscope EEA surgery we did. So last year when I go there, we do the transorbital surgery and for sphenoorbital meningioma. They have a lot of huge sphenoorbital meningioma that you don't see in the United States and Taiwan due to the hormone use for like a birth control. So we did some difficult cases. It's invading the basal ganglion. So after we removed the tumor, the one Indonesia colleague asked me, where is that part of the brain? I say, oh, it's basal ganglion, and that artery is lenticular striate. He say, oh wow, really? And so I saw lenticular striate. That's the bleeder of basal ganglion ICH. That's when we had came up this idea. That's the eureka moment. We can tackle this. This is the conventional method, minimally invasive method that you all are familiar with. Why don't we use the orbit, which is a natural separation between the frontal and the temporal lobe, and tackle the ICH through this little part of the brain that we go through. So this is the transorbital approach. So I like to echo my mentor, Dr. Lawton, how he tackled the basal ganglion cavernoma. So if we can do ICH surgery as elegant as microscopic surgery, I think we will be very successful in basal ganglion or thalamus. So this is what we do. He have a very, Dr. Lawton has very good illustrator. So going above the lenticular striate artery, this is called the supracarotid approach. You can remove the, working between the lenticular striate artery, you can remove the cavernoma. So you need to do a FOZ for this. But for ICH, it's just a really simple burr hole. So this is the approach that he mentioned. So this is the approach that we do. It's like a, orbital roof burr hole, and you can remove the clot. Yeah, using not just the device we created, but any endoscopic technique, you can remove this. So this is some of the cases that we did. You can see the orbital roof burr hole and the evacuation of the clot. And this is another case. Yeah. So this case is interesting. Like you can go through this is 1 centimeter. You can go through here as well. But so we think it's also very close to here. So we tackle this way. So it will be very interesting to discuss about the important fiber track, which I will show you later on. So this is the navigation system. So we decided to tackle this cavernoma using the similar method. This is a very rare case because they have rebleed. So you know the important fiber tracks.
Fusion tensor imaging with tractography was.
So
These tracks will.
this track is very important. Alcinate fasciculus. On the dominant side, if you damage it, you will have naming problem. So as you see in this case, it's a good trajectory using the transorbital. So, but not many ICH patient can get MRI tractography during the acute stage. So we are working with NVIDIA on some project that using CT, you may predict some fiber tract place in the emergency setting. So this is one project we need to think about important tract preservation. And I think at the early stage of our minimally invasive surgery in Taiwan, we damage a lot of FAT. Yeah, so you know, it's emergency life-saving surgery. Nobody think too much about these tracks, but I think we are in another different era now. So we need to be elegant as Dr. Lawton. So this is the surgery that we did, like this is so because we want to use the microscope, we have to use so we can do bimanual technique in dissecting the cavernoma. So this is the exposure you can get from it's like a mini OZ. Then you can use the trocar. Then we use the Vicor. This is the durotomy. Also, yeah, so Indonesia fellow. Yeah, so we work with them a lot.
Eventually, the mini corticotomy is made.
And later on, it's the dissection is very easy. So because there's no active bleeder, and you can see some lenticular striate artery near. So dissection of the gliotic plane.
Vessels were identified and preserved.
Very small ones, but yeah, you work within these lenticular striate artery, like this one larger. So it's you just need to be careful, and I think you can do this with endoscope as well. So after surgery, you see it's like the MRI, and the incision is like this. Almost, I think the healing is very good in this area. So this is the post-op image. So we showed that we can do this. You don't need a FOC, you just do a transorbital. So it's pretty good. So I think in this era, we can tackle the lobar ICH. Dr. Pradila did a great work on that, and we can tackle the basal ganglion part together. And as for thalamic, it's even harder, and I'm very interested in that because Chris invited us for a talk on location-based ICH surgery back in 2019 in AANS. So there's a lot of discussion about thalamic ICH, which I will show you. And cerebellar ICH minimal invasive surgery, I think Dr. Dr. Kellner did a great job on that. I don't know if you know that in China, some aggressive neurosurgeon remove basal brainstem ICH as well. Integrating technologies like robotic surgery, I think in the future, in selected cases, maybe it can be done. So just like I mentioned, if you can do this kind of surgery as elegant as cavernoma removal, you can do this, no problem. So for ceramic ICH, there are different location, and for example, the medial ones usually have IVH, and emergent surgery sometimes needed, not just for the ICH, but for the acute hydrocephalus and IVH. So our device is also very good as a ventricular scope, suction irrigation, and cauterization. I think you can think about it as like using the scuba technique. It's like an improved version of the ventricular scope. So like for like for the ceramic ICH, you can tackle through different angle, even contralaterally. So many people do it differently. So this is how Lawton think about different nucleus. I don't know if we need to identify which nucleus has the leader, but I think this is something we can think about to do it very elegantly using the navigation system and pole system. I think this can be done in selected cases. So I think the tracks are very important when you tackle the ceramic ICH. Okay. So the last part of my talk, I will just briefly mention what's more exciting because right now we can do surgery to save these patients' life and they can recover, but most of them have hemiparalysis or aphasia. So I think AI can help these patients. So in my hospital, we work with NVIDIA a lot, and this is last year. The superintendent and we visit the headquarters, and Ms. Powell, their CMO, visit our hospital. We think about how to identify the important fiber tracks during acute surgery. And Elon Musk's Neuralink project, also the Synchron project is very big from Mount Sinai. And so also Eddie Chen's brain-computer interface, we work with him a lot. He just got investment from TSMC, a very big Taiwan company, and working on projects like this. I think now we need to think about vertical integrations. For example, Phys AI, they can help select the patient, refer to like New York ICH patient, refer to Mount Sinai to the ICH team. And later on, if needed, they can be treated, preserving these tracks. And we can use like the brain-computer interface or neuromodulation technique in the future to help these patients regain their function or improve their quality of life. So this is the end of my talk. So why it's called connecting the dots, because I never thought about doing all of this in the last 10 years, but I feel excited about the future works that we can do together. So very thanks to our patients, and 3F is friends, foes, and family. And I'm glad that to have friends like Chris, and we hope to continue working together. I think it's very exciting to do medical device innovation, biomaterial, also some brain-computer interface projects together. Yeah, thank you very much.
Awesome, Abel. Thank you so much. I didn't know a lot of the story of the
Yeah,
origin and your going to BioDesign, and that was really awesome to hear.
yeah,
Um,
thank you so much.
I have so many questions to talk about, but I'm gonna open it up to the audience here.
No
Any
problem.
questions
Yeah,
from the audience?
yes.
There are a lot of specifics that you touched on about
Hmm.
improving the where the location-based procedures. You know,
Yes,
we have done minimally invasive ICH evacuation for thalamic hemorrhages, and we've also
yes,
done them for cerebellar hemorrhages.
yes,
And like you showed, the outcomes in those patients, the real estate is more sensitive, and those patients do worse. from the outset. And so, can you move the needle by removing the blood and help those patients? That's, I think, going to be a harder thing to prove, especially now that they're getting excluded from the clinical trials,
Yeah.
because people have observed that it's challenging to it's challenging to perceive improvement for those patients. So we actually have stopped doing thalamic evacuations, and we put out a paper of our first 20 doing endoscopic evacuation, and
Hmm.
we didn't do anything comparative there, but just overall they were doing poorly long term, so we stopped doing it. In terms of cerebellar hemorrhages, I have done that, and I do like that. The hard thing with that is you have to really get all the blood out. You have to be very confident you're going to completely decompress, because you're going to have some edema there, and the patients who are coming in debilitated, they're going to remain debilitated for a few days, and you're going to have to be very confident there's no residual pressure on the brainstem. So you have to be a little selective with those, I find,
Yeah.
to know that you don't need to do a decompression.
Yeah, that's actually a very important point. So for thalamic ICH, in my hospital, we are aggressive only if it has IVH and acute hydrocephalus. We will go in, and if we see the rupture site, we will go into the thalamus. But if we don't see the rupture site, we will just remove the IVH and relieve the acute hydrocephalus. Yeah, these patients recover very slow. Yeah, so as you mentioned, so I think there's no data to support us to be aggressive on removal of the thalamic ICH right now. But if we go in to remove the IVH and relieve hydrocephalus using ventricular scope technique, maybe if we see the rupture site, we can remove some clot. Yeah, I have some video showing, but this one does not play the videos. Yeah, sorry. But I think only in very selected case you can do this. And so if you can predict a rupture site is from the above or from the posterior trigone part, you can go through the different trajectory. But that's something that we can think about. Right now, there's no evidence. And you are right about cerebellar ICH, because there's debate and there's no guideline whether or not you should do the craniectomy, like the usual remove of the skull after this kind of surgery, because you cannot predict the brain edema. If you can predict how much brain edema volume after ICH surgery, you can know whether or not you should remove the skull. Yeah, but for early cases, ultra early cases, usually you remove the clot. There's minimal brain edema. I think you
Yeah,
also showed that in your work. That's why ultra early works better for minimal invasive. So if delay after 48 hours, the brain edema, the secondary injury already started, maybe
yeah,
craniectomy is needed. I think, yeah,
yeah.
yeah,
I think
that,
it's even earlier. The mirror registry, we originally were thinking we would do 12 hours,
yeah.
and we discussed that it's rare that people get nowadays these cases in 12 hours, and so to be
Mhm.
able to really get good enrollment in the trial, we broadened it to 24 hours. Now it's 24 hours for this registry. So, but I do think there's, like you said, time-based edema risk. So that as the hematoma is in there longer, you're going to have more post-operative edema related to the original secondary injury.
Yeah. Do you use ICP in these patient after after cerebellar ICH removal? Do
Yeah,
you put the ICP? Okay, I see.
yeah. Normally I just put it in an EVD,
Oh yeah, yeah,
and EVD and put in EVD and then do the minimally invasive evacuation.
I see. Great. Yeah, thank you.
Abel, hi, I'm Brian Jenkins.
Hi,
I know,
hi, hello, sir.
hey, I
Nice
greatly
to meet you.
enjoyed your talk. I
Thank you.
was particularly interested in your comments about foregoing MRI, but still wanting to be more selective in your approach using perhaps large scale DTI um, sort of atlases to overlay on a CT scan. Can you tell us more about how far you've gone in creating some kind of CT-based fiber tractography atlas that you can use in real time in surgery? How far away
Oh,
from that?
yeah, that's just a project that initiated working with the bioengineering department. I think from last year. So in my hospital, the protocol for ICH is that the acute ICH patient gets the MRI almost in the first 3 days. So we can use the CT, the acute stage CT to correlate with the 3 days tractography. So they can use AI algorithm because I'm not an AI expert, but they use these data, CT and MRI in the same patient to correlate. And on CT, it's important. It's easy to see the internal capsule, and they can use that to predict the track shift and the damage. So I think they need, right now we only collected about 35 or 36 patients. So right now, I think it's still a work of progress. We also work on the connectome, but right now there's a big debate on whether connectome is clinical relevant, but that's something that we worked on. It's a project by my colleague. So if you are interested, maybe we can have some discussion on that. Yeah, because I think it's very important and has clinical implication in the future. Yeah,
Agree.
yeah.
Yeah, my sense
Thank
is you don't need a new tractography scan for each
you.
individual patient. You get the CT, you merge it with, an average tractography. I think that's probably enough to
Mhm.
guide
Mhm.
your your approach.
Yeah, yeah. And
You might
yeah, please.
you might not even need a patient specific approach. You might need an approach that's tractography conscious, that you
Mhm.
develop and then show that over multiple patients, there's enough consistency between patients in the tract location that as long as you're using the standard approach, tractography guided approach,
Mhm.
that's good. Kind of like what you showed with the transorbital approach.
Yeah, yeah. Yeah, so yeah, that and I also heard that the portable MRI, what's your experience? The portable MRI, do you use like you can
Yeah,
use to do tractography in these patients? Do you think in the future?
we're talking about getting one here. We haven't got it yet, so more on that to
Okay,
come for us.
okay, okay. I don't know if that will be useful for this tract-based surgery. Yeah, but it will be important. Yeah.
Alo,
Hey,
can you
Abel, hey,
stop? Oh, go
hey,
ahead.
it's
Somebody
Ted
else.
Schwartz. I have to
Hi, Dr.
run.
Shaw.
How are you? How are you? So nice to hear you
Yeah,
talk.
many years ago, I attend your workshop.
Oh, you did. That's wonderful. Well, you've
Yeah.
you've come a long way, and I'm really encouraged to see all the great work that
Thank
you're
you, sir.
doing. And
Yeah.
I'm excited to be here at Mount Sinai to collaborate with Chris and help in any way I can. I just wanted to
Yeah.
mention, I have done a lot of transorbital surgery and supraorbital surgery. And there's a
Yes.
whole, group of us who come to it not from the ICH world,
Mm-hmm.
but from the skull-based world, using
Mm-hmm.
endoscopes to show that you can access, the medial temporal lobe, you can access the insula, obviously frontal lobar hemorrhages as well.
Yeah.
I think it would be a very fertile um, grounds for collaboration
Yes.
to
Yes.
show that, with the transorbital approach, a lot of these ICHs that require corticectomy through
Mm-hmm.
traditional approaches
Yeah.
and may traverse, deep white matter tracks can be done through the orbit in ways that will be much more conducive to faster recovery. So I was just curious if you've done any, for example, insular
Yeah.
ICHs
I
through
did
that sort of
some.
approach.
Yeah. So actually, yeah, after learning from you and also our colleagues like in Seoul University, we are very close together. And so they tackle the insular glioma through the transorbital approach. That's where we also started. We have some experience in that. But the insula, there's the common hemorrhage is putaminal hemorrhage. So there, I rarely see insular ICH, but we tackle some ICH in the temporal side from the transorbital. It's also very useful. So I think in parenchyma lesion that we some tumor we tackle through the like metastasis frontal base. Sometimes we can do it through the transorbital. We also tackle some MCA aneurysm using the transorbital approach,
Yeah.
which other people done already. So,
Yeah.
but I think it's important to choose microscope and the endoscope or between. For example, clipping an aneurysm, I feel more secure using the microscopic technique, but that's just a
Yeah.
little bit uh orbitotomy, just a little bit more. The wound is just a little lateral. I think that's a very uh useful technique. Yeah.
Wonderful. Wonderful. Well, thank you so much. I have to run,
Thank
but it
you.
was really wonderful talk. Thanks. Take care.
Yeah.
Bye bye.
Thank you, sir. Bye.
Abel, we just have 2 or 3 minutes left. I was wondering if you could talk about how you got going doing ultra early evacuation in your clinical practice. I know you were doing that way back in the 2000s. And has that changed at all over time?
Oh, okay, yeah. So we started doing ultra early because this is actually I don't know why we have so many patients that deteriorate so early on. So I think I always want to do a trial because on patient that's deteriorating. So the data shows that the ICH patient deteriorates about 30% of the patient deteriorate in the first day, I think, yeah, and mostly within 6 hours or something like that. So we have much more than that. So in deteriorating patients, we will do aggressive surgery. Yeah, so that's how we started doing ultra early surgery, and I think we received a lot of early cases. That's why we did that 2011 paper in neurosurgical focus. But I think the important thing is that these cases, many have bleeder. So if you use endoscope minimally invasive surgery, it's if you have confidence in cauterization of management of these bleeder, you can do it, or else you will have many catastrophic consequences, rebleeding. Yeah, so we have some rebleeding on early cases. So the important thing is to integrate suction irrigation and the cauterization. These three are the key. Yeah.
That's great. Are you still doing it like that? Have you changed, recently at all? Or is that
Oh, right now we just use the ClearMind device is still not available in my hospital, but in other hospital in Taiwan. So I still use the old technique, but I use the five core sheaths because we don't have the nickel sheaths. Yeah, so just I think any tubular retractor will make it, and I think it's a very versatile approach because initially you use the smaller one and you evacuate the clot. If there's no bleeder, that's done. If you saw more obscure bleeder and suspicious bleeder, you just change to the larger trocar. So maybe it's like the trocar with the diameter of 17 millimeter, you can put in the bipolar. And if needed,
yeah,
you can also use the endonasal bipolar that can be used through a very small tubular retractor. That's all the experience there. So I think really, like Dr. Schwartz mentioned, like a endoscope and microsurgical technique, we can learn from each other. So we can get those skull-based bipolar and work through a very small trocar to do judicious hemostasis. Yeah.
if you're in with the smaller trocar and you get
Hmm.
into bleeding, do you
Yeah.
sometimes exchange out for the large? You take it out completely and then you put in a larger one
Yeah.
when you
So
said,
of course you can use something like a stylet or something. Anyways, at the initial innovation stage back in 2005, I think we put the Foley on the trocar, like a Foley balloon
yeah,
Foley. Yeah,
ah,
yeah, 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 yeah,
to hold it there and then you exchange out and exchange in.
yeah, 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 yeah. You
Okay,
can.
that's interesting. Yeah,
Yeah, yeah. Oh, you can use something like the stylet, when you change the the tube, the endotracheal tube, you can
yeah.
use the stylet. Yeah, but I think we just remove it and put back a larger trocar. Yeah, it
We
also
also
works.
have we have the surgiscope and the Aurora evacuation
Yeah,
device
yeah,
in the US available. And that,
yeah,
I'll use for deep lesions, I'll use the lower diameter device, which is, I think, 9 millimeters. And that fits the Aurora device in it, which has this bipolar cautery on it. So you're able to cauterize and aspirate and irrigate with that. And then I found
yeah.
myself more often with the superficial lesions, using the broader device, which is 15 millimeters, I think, and it's similar, diameter to the uh, Nico, now Striker, brain path, larger one. So I've kind of found myself using, the lower diameter for the deep lesions and the broader diameter for the more superficial lesions. But I think
I
everyone's
see.
kind of developing their own technique, with the different devices. Brian, I think you were also doing something like that.
Yeah,
I saw
yeah.
him go off mute for a second there. Yeah.
Yeah. Yeah, yeah, I think I agree with you. For the superficial lobar ICH, many surgeons think that after they saw Dr. Predila's paper, they think that just using like a retractorless surgery, use bipolar and the suction, you can
Yeah.
do many more invasive surgery. So just like you mentioned, it's like a larger trocar. If your
Yeah.
microsurgical technique is good, you can just do that. You don't need that trocar. But every surgeon have their preference. I just think that we can find the approach for different location, just like you mentioned. We use different technique for superficial and deep ones. Yeah.
All right, Abel. Well, thank you so much. It was awesome to hear the whole
Thank
story.
you.
And also, I'm very excited about some of the things you mentioned as things to be
Mhm.
excited about to come.
Yeah.
Thanks a lot. And I think we'll
Thank
wrap
you.
here.
Okay.
All right, everybody. Have a great day.
Thank you. Bye.